This conference will now be recorded.
Hello, everyone, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat for Monday, June 15, 2026. I'm Len Sierra, and I'll be moderating today with a little help from my fellow moderators, Rick and Dr. John, and all of you, our very well-informed and well-educated attendees. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. And as always, we want to acknowledge and thank our sponsors, and they are Foundation Medicine, Novartis, Telix, and Blue Earth Diagnostics. So, Rick, thanks to the, wonderful life I've led without any sin whatsoever, we have no newbies. I have a clear path to the end.
I think we do have a newbie because I can see. Well, yes.
Who's new?
Well, Bill Lawler is new to this group.
Oh yeah, Bill. I skipped over him because his.
Because why?
Camera. Okay, good. So
and what I'm gonna do is I will give a quick summary for Bill.
Okay.
Since I have it, and I don't think anybody else does, and then we'll go back and ask Bill to fill in any gaps. And so I'm just pulling this up, and so that will get us. So this is really you still living a good life, Len, to be honest.
Okay. You get to do my newbie interview.
Yeah. Let me just.
Did you mention the sponsors in the recording?
Didn't hear that.
Yes, he did. Yes, he did.
I was not. Oh, wait a minute. I'm in the wrong. I've got. No wonder I'm not getting anything. I'm in the wrong place here. I'm trying to figure out what's going on, and now I should pull it up because I know I have good notes on Bill because Bill and I have been talking to each other. So this is Rick, and I am just going to give you a short summary of Bill Lawler's background, and then I'll have Bill amplify it. But it's a story we've been hearing fairly frequently recently, and it's a story that, as much as we don't want to receive anybody into this group, I think there is optimism. Bill has graduated through two groups to get here. I think you started, and you'll correct me afterwards, Bill, where I'm wrong or where I made a mistake here. Bill started in the active surveillance group, I believe, with a 3+4. I'm not 100% certain, but I think it is. Bill will correct us. He was in active surveillance, supervised Massachusetts General for a long time. He's 72 and he lives in the greater Boston area, works in the TV business. And probably about 2 or 3 months ago, and again, he'll tell us, we graduated him to the low intermediate group. And I think I think Dr. John probably has some notes on Bill Lawler from the intermediate group because his PSA had gotten over 10, and over 10 means you probably should be thinking about treatment, except in special circumstances. And because his PSA was climbing like that, MGH decided to do a PSMA scan. His PSA had gotten to 14.5, And sure enough, they found a small lumbar lesion. I think it was either on T3 or L3. Bill, you'll correct me. And so they referred him over. They stayed in the picture, but they referred him over to the two docs that I probably would have chosen at Dana-Farber. One is Atish Chowdhury, who many of you have heard me talk about before, who we like very, very much, and who is very concerned about quality of life. He's running a trial about quality of life right now, and he's one of these guys who really believes in avoiding hormone therapy for as long as you possibly can. And I forget the name of the trial. Somebody will remember it. I'm guessing it might be Jeff Markey, whatever the name of his Atish's trial is called. And we've had people in that trial. And then they also referred him to Dr. D'Amico. And when Bill and I spoke on the phone, I also thought he would be an ideal candidate for Andromeda with Kishan at UCLA, where they look at metastasis-directed therapy, meaning radiating the metastatic lesion, and they're adding either one dose of alpha particle or 2 doses of beta particle radioligand therapy, and there's no hormone therapy involved. So that is my quick summary, and I got a correction. It wasn't T3 or L3. I must have been thinking about my buddy Dave Fisher, who's trying to get into that trial. Or David Muslin has been accepted for that trial. It's his left iliac bone. So, Mr. Lawler, please add anything that I missed and correct anything. I don't think you have any genomic abnormalities. I'm not sure if they've tested you yet or not, but I don't have any genomic abnormalities written and noted. Oh, don't tell me we can't hear you. It looks like we can't hear you, Bill. Make sure that the right microphone is selected. Go up to the settings and make sure that your microphone is correct. If it isn't, the best thing I can say is go out and come back in again. What a bummer.
I think that's why I had skipped over him the first time. I didn't see any microphone at all.
Well, there's a microphone and it's showing that it's on, but it's not connecting. All right. We'll come back to you as soon as we can hear you. Go out, come back in again, see if that does the job. And I'm also going to put the telephone number, I'm going to pin it to the top for to call for assistance. I wish I could bloody remember this. I always get it off by one. 582-7011. I was right this time. 7011. And I'm sending that to everybody, and we'll pin it to the top. So, and we'll pin that. Okay, so that's the number. All right, Len. We can't do any more work with Bill until we can hear him. Oh, and Bill, if we can't get you, you'll have to call in. I'll send you instructions how to call in as well.
Okay, then we will move on to Dan in Schenectady.
Yeah, it's just an update. My PSA went up to 1.77 from 0.4, and so I had a PET scan on the 3rd of this month, and it revealed that I had my left posterior rib it metastasized. The cancer had metastasized there. My T10 vertebrae, my right posterior seventh rib, and my right inferior scapula, and the left clavicle head, which was noted before. And I've been having some back pain, so Dr. McHugh is going to set me up for an MRI to make sure that's not related, or to find out the cause of my back pain. He thinks it may be degenerative problems, which I've had in the past. And then he's going to look at medicine, my pharmaceutical changes, and maybe radiation treatment. But I'll find out that on Thursday. So that's just my update, and I'd like to find out what are the possibilities that he'll recommend, for my treatment.
So Dan, it sounds like you have 4 bone metastases, but no lymph nodes. Did I get that right?
Oh, yes, I have a couple lymph nodes. Where was that?
Okay.
Where was that? Soft tissue findings. Yeah, I had 2 lymph nodes. And
Okay.
I had 2 lymph nodes. I can't remember where they were though.
All right. So you got 6 lesions. Unless things have changed, they used to have a 3 to 5 lesion cutoff for metastasis-directed therapy or spot radiation. But they're still telling you they might do that?
Yeah, that's what he said. He mentioned that. That's the last time I talked to him. But he hadn't actually read the report yet, and just the radiologist read it. But and then when it came back, there was more metastases than he had thought there was, from the report, from the radiology report.
Right. And so
where were they again, Len? Rib, scapula, clavicle, and where?
7th rib, T10,
T10.
right inferior scapular.
Yeah, got it. T10.
Yeah.
Yeah, and I had in my ribs, I had it on the left and the right.
So there were two times in the ribs, scapula, clavicle, T10. That's 5, and 2 lymph nodes. Correct?
Yes.
Okay. All right. So you think Dr. McHugh was talking to you about spot radiation before he realized how many additional metastases you had, right?
Yeah, that's what I'm thinking now. Since you mentioned that,
Okay. So what drugs are you on right now, Dan?
Abiraterone,
Yeah.
Lupron, and prednisone.
Right. Okay. And so your PSA has been rising even while you were on those drugs.
Right. Yes, and it was 1.77. I went to the VA and had my regular checkup, my yearly checkup, and it roused from 2.6, and that was between the time that Dr. McHugh took it and when I went to the VA.
Okay. I don't know, guys. Rick, Dr. John.
We know what you're thinking. So say it, and then we'll
Chemo.
I mean,
I was thinking chemo.
right.
No.
Okay. How old are you, Dan?
73.
Yeah.
All right. So
you may say no. You may say no, Dan, but that is what the protocol is. If you've got 5 or more lesions, we can play around with those drugs. We can try and switch them and see if you respond better. But I think most people would say we need to try chemotherapy because it's on the move and we've got to nail it quickly. And that's the systemic therapy that we nail it with now. I think technically you are eligible for radioligand therapy and Pluvicto, but given how early this is really in your disease process, I would say you've got to have a really, really hard discussion, heart to heart with Dr. McHugh if you wanted to go that route so early in the process. I think if it were me, I would say I'm just going to bite the bullet and I'm going to have to do chemo. Bob Schwartz, you've been through this? Go ahead.
Yeah, Danny, I'm going to tell you right now, I've been through it. You can see Danny's on here. He's going through it right now. I'll tell you, it's not easy, but you can do it. I'm telling you, it can be done. It's going to be a little bit difficult. Don't get me wrong. It's going to have its hiccups and ups and downs, but it's worth the result. Take the advice you're getting from Len, Rick, and everybody else on here. Don't say no. I was a no-sayer before, too. I was definitely against it. No way in hell was I ever going to try it. Yet I saw the benefits, and it works. Don't write it off. Please don't.
Okay, so how long were you on it?
I went the full treatment.
Well, how many weeks, sir?
It's one shot every week for 6 shots. That's 18 weeks.
Okay.
And believe me, it's not going to be easy, but you can come to this group. You'll get support. You'll get people to talk to and things of that nature, and they help guide you through it. And you can see people have survived it. All right? You could survive it, too. Believe me, if I survived it, you could survive it. I'm a wuss.
No, you're definitely not. But anyway, yeah, once every 3 weeks, Dan, for 6 cycles. Okay, so 18 weeks.
Okay.
Now, there are some doctors who are saying that they use a lower dose, but more frequently, like maybe every 2 weeks or every week, and they use lower. Lower dose, but more frequent infusions. And at least I can recall from Dr. Sartor, who is well respected in this field, saying that when he's done that, the side effects are less and the effectiveness is just as good. So, talk to Dr. McHugh about dose adjustments.
So that's less.
Lower dose. Lower dose, but more frequent. Yeah, more frequent infusions.
Okay.
There's something to talk about. Let's see. Larry had his hand up. Go ahead, Larry.
Yeah. Okay. Dan, 7 years ago, I went through chemo and it was a pretty rough time for me. I didn't even finish the 6 cycles. I think I only got through 4 because I was getting rashes and other problems.
Right.
And I had those cycles and I had, it was effective and like it lasted pretty much with the Lupron, and I had darolutamide for like 4 years. And I went to the gym feeling pretty good, and I had some new metastases, which they were able to zap with SBRT, with radiation. And now it's 7 going on 8 years, and I'm enjoying my life. I certainly didn't enjoy chemotherapy, and it was problematic. So I have to say that maybe I was a lucky one, but here I am. It's 8 years later, and I thought I was on death's door, and I'm not. So unless the doctor offers you something else to try, I mean, they can do what Rick said, is something where you switch around. Maybe you can try another, not abiraterone. Maybe you can go to darolutamide, which I did. But you can take your chances, but I don't know. Maybe with just the fact that it's 6, how are they going to radiate 6 places? It's going to, when it came back for me, it came back to 2 places. That worked out okay. Now I'm happy that I did all that. That's all I wanted to say. So people here who have been through it like I have, and it was very hard for me. I got terrible rashes, but I made it through 4 of them, and now I'm fine. I mean, I'm stable and happy. So just want to share that with you.
Besides the rash,
And may I just add, Mr. Fish, you lived long enough to see the Knicks win a championship again.
Let me live 53 years and then we'll talk.
Bob Schwartz, you have your hand raised.
Dan, one more last thing, and I'll leave you on this. And you're already partway there. You don't have to worry about the hair loss. You've already got it. That's the hard part.
Oh, Dan, there's actually...
I'll lose all the hair on all my body now.
Dan, there's actually one other option you might want to discuss with Dr. McHugh, which is some people, when they become resistant to abiraterone and prednisone, they switch the steroid from prednisone to dexamethasone, and they kind of get it resensitized to the abiraterone, or it works better.
That's say that what's the switch?
Dexa, DEXA, methazone or methasone, depending if you're British or American. Dexamethasone, METHASONE.
Okay, got it.
I'll put the reference in the chat, Glenn,
Oh, thank you, John.
if I can find it.
That's dexamethasone with the abiraterone.
Yes, it replaces the prednisone.
You know, my concern is this. If it were me, this is where I would be really concerned. It's all well and good playing around with the steroids if you see your PSA rising, but we've gone a lot further down the road than seeing the PSA rising.
Mm-hmm.
We've gotten to a point where we're seeing multiple lesions, and I not a doc, can't say. Maybe one of the other docs in the room wants to give you their thoughts, but I think that we've got to take more serious action, because if we don't, we're going to see lesions in a lot more places, and we've got to cut this off at the pass. 3 months ago, we weren't seeing any lesions, or maybe possibly one. Now we're seeing 6 or 7. If we don't get on this and do something radical, this could be pretty significant, and we don't want to see that, Dan. So that's what I say. You have some other... Oh, no, you don't have any hands up now.
Well,
So,
I agree with Rick, Dan. The only reason I mentioned that was because you seemed like you were pretty resistant to chemo, but Rick is right. In this case, you may not want to waste time trying to switch steroids and wait and see what that does. You might just want to hit it head on with chemo.
So, what can I expect with the side effects besides rashes?
Well,
go ahead.
Oh, here's Danny. Go ahead.
Yeah,
Danny.
Danny, why don't you take that one on, since you're going through it right now?
Hey, Dan, I'm kind of losing my voice. That's one of the side effects. Chemotherapy kills all those fast replicating cells. So things like skin, hair, nails, throat lining, all of those things, your tongue cells, they all kind of turn over real fast. So those are some of the side effects. You lose a little bit of your taste buds. I get red in the face. If you can't see my face right now, it's pretty red, right? It'll flare up. That's the rash that I think Mr. Fish was talking about. Sometimes it feels a little bit like a sunburn. You get a little bit of GI tract issues. It's a whole host of things. You just kind of feel sick a little bit. But here's the thing that got me to do it. I said no to chemo as well. And, when the doctor said, well, without chemo, you've got 18 months, maybe, that's when I said, okay, I'll do it,
Mm-hmm.
So you can get through it. I think I'm halfway through. I'm doing docetaxel, 6 sessions, 18 weeks, every 3 weeks. After the first week, you kind of start to recover and you get back to normal a little bit. And then you go back and do your next session, and it's painful for 3 to 5 days or so. And then you start to get better, and you just rinse and repeat that 6 times.
Is it docetaxel? Is it the chemo treatment?
That's
Yes.
the drug, Taxotere or docetaxel. That's the drug I'm taking. Pretty common, I think.
Yeah.
But it's doable. I mean, they give you drugs like, I get dexamethasone to offset the side effects. I get prednisone to offset the side effects. They gave me a stimulant, Adderall, to kind of keep me awake and working because I'm still working. So, you can treat it. You can't do too much. That's the problem I had is I kept trying to do too much, my daily routine, and I'd wear myself out. And you got to keep yourself in between the lines of doing too much and not enough, do a little exercise, but don't go overboard. That's my problem right now. So that's my share.
Yeah, that's great advice. Dan, one of the things that I would strongly suggest, if you don't have it in place already through Memorial Sloan Kettering, is that you need a palliative care doc on your team.
Okay.
Now, a palliative care doc we're not talking end of life at all. They are the people that handle symptoms. And so Dr. McHugh may not necessarily be up to date on all the latest stuff that's there to handle symptoms. The people at MSK are really good. They have a good palliative care group, and hopefully Dr. McHugh will refer you. If he gives you grief and doesn't want to refer you, tell us. We'll tell you how to go around him.
Okay.
Because there are some docs that don't, but most smart docs will say yes, of course, and you'll be assigned a palliative care doc. And then when you do have issues, whether it's the rash, whether it's fatigue, whether it's nausea, whatever it is, they're going to be there to help you. That is their job.
I see. Yeah. Okay. Yes. Yeah.
How does your wife feel about all of this?
I haven't told her yet. I haven't told her. I have this first time hearing that I'll possibly taking chemo, and she's against it. But if I want to live more than 18 months, and that's the best care for me, I might have to go through it. And so, but right now she doesn't know. Yeah,
I think so. Dr. John, any suggestions, words, any help for Dan on that one?
Yeah, well, I'm glad you guys are sensitive to the issue of wasting time with an ineffective treatment. If you don't have that time to waste, you want to get the most effective treatment as early as possible, right? To get the longest life in a situation like that. So that's the philosophy that the guys are working on when they talk about chemotherapy, Dan. The trial of Pluvicto would actually take quite a long time. And it would delay your time starting chemotherapy by a long time, although I have heard of some people trying both drugs at the very same time, but that's quite rare. The idea that Len had on a previous week of switching to dexamethasone, this was a small study done quite a long time ago, but a pretty significant number of people, for kind of bewildering reasons to me, had a good PSA response. And that probably would only take, I don't know, Len will know better than me, but that would probably only take 2 weeks or something like that.
Yeah.
But still, it violates the idea of best drug first.
Let's see. let's see. Larry, you took the chemo. You've been like on a holiday for how long?
I'm not on a holiday. I'm still taking Lupron and another drug, darolutamide. It's an alternative to abiraterone that you're on. And I've been on that drug for many years. My PSA was very low after that and stayed low. And when it came back, I did the thing that you're talking about. I did some spot radiation 3-4 years ago, but it stayed long 3 years ago. It's still low. And I had more than just simple rashes. I had serious side effects, and I had to stop because of the rashes and the peripheral neuropathy in my hands and feet. It got serious enough that they felt like it was dangerous to keep giving me, because the rashes could be internal and affect an organ. But anyway, as it turned out, it was okay. I mean, I recovered. My hair grew back. My neuropathy is not so terrible. It's bad. I'm not the same person I was, but I'm enjoying my life. So I'm glad I have it. That's what I want to say. It's not, it's difficult. I mean, as Danny's in the middle, it gets hard as you get near the end, but I guess I did enough to suppress everything. And now I'm waiting for the next drug that's going to cure. It's going to run through my body and kill any remaining cells. And I was, around 70, 69, 68. Now I'm waiting to be 90. I mean, I want the next drug to come out. That's how I feel. But you're not going to like it, I can promise you.
Yeah. So I belong to I'm halfway through the Live Strong program.
Oh yeah.
I was wondering, is that too much exercise, and I do water aerobics too, so I wonder will I have to cut that?
I mean, Danny said he had to moderate what he did. I'm the opposite. I think I didn't do enough, and now I'm working out 4 or 5 days a week because that's the most important thing that I can do for myself.
So Dan,
I would say, and with a question like that, first of all, let's see how long it is before you start the chemo. It may be another couple more sessions, and then what you'll do is talk to the Live Strong trainers, and they'll adapt for you because they're experienced in doing that.
Right. So is it likely that he'll drop the abiraterone and the prednisone?
Probably not. He'll probably leave that. It's called triplet therapy. That means 3 parts, and he might try starting it and switching you to a different one. I don't know, but I don't think they'll drop any one of those 3 parts. They may chop and change them, but they won't stop any one of those 3 parts.
Right. Is there any treatment I can receive that would avoid the prednisone?
No, only if you switch to a drug other than abiraterone. As long as you have the abiraterone, you need the dexamethasone, or you need the prednisone with the abiraterone.
But if they would switch you to darolutamide, it's an easier drug to tolerate.
Okay.
Got rid of the severe brain fog and confusion I was starting to feel.
Yeah.
So now look, I'm sharp as hell. I can play chess. I can. I'm working, and like Dan said, I had to, not work for like second day 2 for a week after each episode, after each session. But then I went back to work. I went to the meetings, did what I had to do, and I'm still working. 70, gonna be 78.
Right.
Baruch Hashem, as they say.
Dan,
As they say.
Dan, you don't have any genetic
No.
mutations? No. Okay.
No.
Dr. John, go ahead.
Just a comment about exercise. Exercise is still good for you and important and will help you cope with chemotherapy. Once in a while, a bone metastasis will be placed just in such a way to make a certain kind of stress on the bone actually break it. So find out from orthopedic doctor or from your oncologist whether it's okay to be, banging your heels on the floor or something like that, so you won't send shockwaves into a bony metastasis and break something. Usually, we prostate cancer got a fun kind of metastasis that thickens the bone, but it's not really strong.
Okay.
And is it okay with you if we move on? When are
Yes,
you
that's
gonna
fine.
Yeah. When are you going to see Dr. McHugh?
Thursday.
Okay.
Thursday.
So yeah, come back next week after you see him, and
The
we'll
other
pick it
thing
up
I'd
there.
say,
See what he says.
the other thing I'd say to you, Dan, on Thursday is record the conversation. So you
Yes.
can listen to it again later. Okay, and you can
Yes.
listen with your wife. If your wife goes with you, that's the best. If she doesn't, she can hear it. But I really think you need to record that conversation, and then you'll come and talk to us next week, and we'll help you.
Okay, yeah, because that's what we did the last time we visited with him, and we recorded the whole conversation. I used ChatGPT to to make it clear for me, and I used it to create a 3D image of where the cancer was. Some of it was wrong, but but I had a good idea where it was, and also so I'll do that again, so.
Okay.
Thank you.
So Rick, you say Bill Lawler is back?
Bill Lawler's back. Can we hear you this time, Mr. Lawler?
How's this?
Oh,
Yeah.
perfect.
I can hear
Perfect.
you. All right.
Perfect. So, just to remind everybody, Bill has a very slow growing cancer that was treated with active surveillance for a very long time, and everybody was pretty happy with that because we didn't see reason to progress. And then all of a sudden it took off, and 9 years later, we've got a lesion that's popped up in his iliac bone, and we're going to treat it with some type of metastasis-directed therapy, either at Dana-Farber, or I've encouraged Bill to consider the Andromeda trial. So, Bill, now we can hear you. You can tell me that that's all a load of codswallop, but that isn't the case at all.
You tell my story better than I do, Rick.
Okay. What would you like to add?
Yeah, you have any questions for us, Bill?
No, it's like the two docs that we talked about last week, the two that Rick named earlier. I'm meeting with those two on Wednesday of this week to actually talk about how to confirm the scan, to make sure that what the scan is what is the plan B on confirming that the scan is accurate, or we just go by the scan and that's gospel.
Right. It was a fairly low, correct me if I'm wrong, but it was a fairly low SUV, wasn't it?
It was 2.8, I believe.
Yeah.
Oh, I'd be suspicious that that's the cause of his, what was your PSA, 14?
14.
I mean, 2.8 is pretty close to the background radiation. I don't know, I think you should talk to your oncologist or radiation oncologist about that.
It's not only close to the background radiation. I mean, we don't know what the background radiation was, but It's probably lower even.
Could be, yeah.
You know, could be a false positive.
Yeah.
Except for the PSA popping, right?
Yeah.
Yeah.
So do you think there's a possibility that the scan is inaccurate?
Well,
Yes, it might be that particular lesion in the ileum might not be an active metastasis. I mean, it's such a low SUV number that it's in the realm that false positives give off. But still, the increase in your PSA has to be accounted for somehow.
All right.
So, you know, a thin beam of radiation at that one spot with no other treatment at all could potentially miss the mark.
I guess there's really only one way to find out is to actually hit it and see what happens to your PSA. The only way you could be certain.
Is to have the treatment and see if the PSA drops.
Yeah, I mean, it's just
Yeah,
one
but
small lesion.
I would say this. Dr. Atish is very, he's a great doc, and he's conservative to treat unless he really feels it's necessary. So, and that's why, I mean, there are other great docs at Dana-Farber, but that's one of the reasons I like Dr. Atish, because he's going to take this all into consideration. So you're going to have two very good doctors looking at that PSMA scan. You're going to have Dr. Chowdhury and you're going to have Dr. D'Amico. And they look at these scans all the time. And I think that both of them, when you go in, you've got to ask them, what do you make of the PSMA? Do you think this is a lesion or do you think it's a false positive? You've got to ask them directly, Bill.
All right. They've also included a third person as part of this team, an Asian woman named Mai Hoon, as part of. She's allegedly a bone cancer radiation oncologist.
Okay, don't know her.
Yeah, she's been around for about 10 years apparently, and they circled her in and they made an appointment with me for her as well, but it won't be till next week. But I'll talk to Atish first and find out what the overall game plan is, because it's like everybody's jumping on the merry-go-round here.
Yeah. But I think that with Atish, you've got somebody who's going to be on your side and not treat you if he doesn't think he has to. So
yeah,
that's the upside. D'Amico, I don't have enough knowledge about D'Amico. I think he's fairly eager to radiate. I don't think he's a particularly conservative from having had other people. Scott Lawler, didn't you meet with D'Amico recently? Where are you, Scott? I saw you came in.
I mean, we have two Lawlers here.
Oh, then it's probably not Scott Lawson, I should say.
Okay.
Isn't it's Scott L? Yeah. Are you there, Scott?
It must be somebody else. I'm in Corpus Christi. I've been going to MD Anderson.
Oh, okay. Sorry. Then I was thinking of yeah. No, I was thinking of somebody else who's going through treatment at this. It was Scott B. He's going through
Brennan.
Brennan, yeah, he's going through treatment with at the same time as Frank Chambra. So, anybody in here seen Dr. D'Amico? So, look, but if there's one person to rely on, I would say it should be Dr. Chowdhury. That would be my guess, but see what they say and come back in next week and tell us. and we may have to relegate you. You know,
Yeah.
we promoted you up here, and it's like the emperor says he thinks that our leagues in this country should have relegation and promotion like they do in England, you know. But that ain't gonna go over very well in this country. But we're always happy to relegate you if you don't belong here. You know that.
Absolutely.
Quick last question, just from my notes. How many years has this since diagnosis, Bill?
I was diagnosed 9 years ago and been on active surveillance since. And in
Okay.
2021 is when we had the first guided biopsy, which is what found the 3+4.
Thank you.
And then
So, Bill, I would just ask them point blank, what are the odds that this might be a false positive, being that it's such a low SUV? Like, how can we be sure? Can we do anything to help clarify whether it's real or not? And yeah, just start with that, see what they say. And we'll see you next week. Okay, Bill?
all right, thank you so much, gentlemen. I appreciate it.
Thank you. David, Seattle, what have you got for us tonight?
Hi. Yeah, so I had seen Dr. E a month ago. She ordered some scans, some blood work. And since then, the scans and blood work have come back. I've seen both Dr. E and my doctor at Fred Hutch. And they don't agree on what they saw in the findings, but let me walk through what the results were.
David, could you turn up the gain on your microphone or so? You're a little soft at my end anyway.
Okay, is this better?
Not really.
Let's see.
All right, it's probably just me.
Okay. All right.
Okay,
So, so the results of the scans, I had shown P10 on my prostate biopsy. The latest blood showed not P10, but it does show something called ERCC3, which she says is not actionable now, but it is relevant. Other than that, the blood was nothing abnormal about the blood. Now, for the scan, the PSMA scan, I had a PSA of 0.04, and they show, the scan shows several lymph nodes that have uptake. And these, from the OHSU interpreting readings, they show that one of the lymph nodes is 0.06 centimeters with an SUV max of 17.8. Previously, it was 1 centimeter with an SUV max of 13.8. There's a left supraclavicular 0.4 cm, SUV max 9.4, unchanged in size. Previously, it was a max SUV of 21.2. Then there's a left 5 cervical lymph node, 0.5 centimeters now, SUV max 13.5, unchanged in size, previous SUV max of 6.4. No new tracer avid lymph nodes, nothing in the bones, and the previously radiated lymph nodes more in the prostate bed were they don't show anything. So Dr. E said, well, that's active cancer, and I don't know why you're not on doublet therapy. Let's start darolutamide now, which I did. So I'm on that, and so she's ordered more scans for two months from now, and to check to see if that really is active. I'm not sure what else it could be. But she
David,
wants
are you the, might be mixing emails up. Did one of your doctors think that it might possibly be sarcoidosis?
yes.
Okay.
Yes. So I didn't get to that. So Fred Hutch doctor thinks it could be something else, possibly sarcoidosis, something else. It could be non-cancerous, is how she put it. And similar statement from her. She wants to do scans. She's ordered scans and blood work for 2 months from now to decide what to do there. Both say continue therapy, current therapy.
What were you on before they added Darrow?
Orgovix alone.
Okay.
And then that was 9 months. So this was supposed to be, when I saw Dr. Cheng, this was supposed to be the decision point to take a holiday or not. So these findings said no holiday, and let's wait and see what happens let's wait and see what happens for the next scan.
And can I just add something here?
Yeah.
David was concerned that maybe he should have been on doublet at Hutch, and Cheng had not put him on. Cheng had not put him on doublet, and one of the reasons we sent him to see Dr. E was for a second opinion, and she did put him on doublet. I'm not sure how Dr. Cheng feels about that, but he's now on doublet.
Yeah, I have not had any interactions with Dr. Cheng since then, other than to send a question about the scans. I am not sure she's aware that these are the same lymph nodes that showed up on a scan in 2025. The OHSU scan report shows that they are the same lymph nodes, but the report from Fred Hutch is they use the word new lymph nodes. So I'm a bit confused too. I tend to fall on the side of OHSU in terms of interpreting it. I certainly don't want to undertreat myself or paint a rosier picture than it is.
David, did you start the Darrow yet?
Yes, I did. Started last week.
Last week, okay. When are they going to do your next PSA check? Oh, wait a minute. Your PSA was only 0.04, right?
Correct. Yeah, a month. I'm doing it monthly, so I'm 2 weeks out.
Yeah. So they won't. I wonder if they could order another PSMA PET scan after he's on Darrow for a month or two to see if those lesions, if there's any interval decrease in the SUVs.
Well, yes, I am getting a PSMA scan in 2 months.
Oh, okay. All right, that's good. Yeah, so then we'll know for sure if that's sarcoidosis related or if it's real prostate cancer.
Yeah, could it be? I saw something, didn't read very much about it, but could it be a flare related to the ADT?
But how long have you been on the ADT?
This is I'm in month 9.
No, you don't. The flare is something that happens right away.
Okay.
I'm not with Orgovix.
Yeah, that's right. Not with Orgovix.
But the good news is we have a sarcoidosis group. So, so if that's what they figure it is, we'll send you to the sarcoidosis. We have had one other guy. We have had one other guy who attended both prostate cancer, this group, and sarcoidosis.
Well, I hope that's the case. I guess I'll just wait another couple months and find out what the story is. But I am a little bit, I guess, troubled. I mean, it may not be exactly the right word, but I have a lot of angst over the discrepancy between the two doctors' approaches.
That could be an ideal cue for Dr. John, who has his hand up.
Oh, sorry, John, go ahead.
Well, this may just be a little, joker in the deck that doesn't have to be paid attention to, but apparently there was a gene test for the PTEN gene, which came up positive. And then some sort of repeat test later came up negative. Just for future purposes, it might be good to actually measure the amount of PTEN loss, if any, in the tissue with an IHC, immunohistochemistry assay. If this is really going to be a major PTEN loss tumor, that may make some different treatment, give us some different treatment ideas, especially now that CAPI has been approved.
Yeah, but John, we're not seeing P10 right now. And my feeling on that is that Dr. E was very much involved in those CAPI trials. So she's going to be looking for something like the presence of P10, and it isn't there now. So she's probably going to keep testing, and she's going to look for other ways. I mean, I would trust her on trying to figure out if David's P10 has a P10 mutation or not.
Well, I'm confused. Were they?
He had a P10.
What was this? Yeah, what was the second test that didn't show? What kind of test?
Liquid
biopsy.
Tempus, yes.
Oh, that's not going to measure the amount of P10 loss in tissue at all. I don't know, probably not significant yet. And of course, Dr. E will never forget it and might look it up someday. But I'm just thinking it's just something to put in the margin and remember it later, to have a proper evaluation of P10 loss. It's just in case that genetic mutation caused a protein loss, P10 protein loss.
Yeah, but John, I don't want to put doubt in people's minds that a P10, that a liquid and a tissue biopsy are not equivalent. I mean, all of the research that we've seen says that they are equivalent. And so if we've seen P10 loss in a tissue biopsy in the past, and now we see no P10 loss in a liquid biopsy, the evidence is largely that's consistent. And there may not be P10 in that. I mean, if she were in that tissue any longer.
Well, your point about not getting hung up on this now is really correct. But sometime I'd like to banter around with the moderators about whether anybody has ever measured P10 loss in a circulating tumor cell from a liquid biopsy. Has it even been done? But that's a question for you and me and Len to kick around another time.
Well, I mean, it does show in liquid biopsies.
I just looked it up, John. It says P10 can be picked up in a liquid biopsy.
Yeah, it can. We've had people who have picked it up in a liquid biopsy, John. I could look them up and send them to you later.
Is that as a gene loss, though, or is that as a real IHC tissue loss? This is for another time. I'll bring it up in an email. I'd like to understand this better.
Okay, fair enough.
One more.
All right, David. So you're good. We can move on.
One more question.
Go ahead.
One thing Dr. E said was, if this is active, then she would consider Pluvicto for me as a next added for triplet. And that, judging from what I just heard from Dan, I know our situations are a little different, but does that sound appropriate, or should I be questioning that?
Look, I think there's a lot of issues going on here. I would not second guess Dr. E.
Got it.
You know, if we sent Danny to Oregon and he wanted to get a second opinion from Dr. E, and Dr. E said, let's do Pluvicto instead of docetaxel, I would say, okay, because she knows, and she's another one that really cares about doing no harm and QOL. On the other hand, when we see 6, I mean, you're not sitting there with 6 lesions.
Yeah.
And you know, the conversation I would have with E on this is, do you think we're using it too early? Or another conversation might be, what about if we just did 2 or 3 and kept 2 or 3 of them in our back pocket? So it's a little bit different. I mean, she may be thinking maybe we can just really, that would be enough to nail it, because we're not seeing the extent of disease that we're seeing that Dan has.
Well, I'm wondering, would insurance pay for that? It's so early a stage when he's only been on Orgovyx.
Well, he's not. He's on darolutamide now, isn't
Well,
he?
now, but you know,
Yeah.
but we don't even know.
It doesn't matter. He's taken it then. You know,
Okay.
the insurance is probably going to say, I mean, it's approved. It's approved. He's done doublet. He's got extensive disease. I mean, the Pluvicto is now approved in that context.
Okay.
The question is it sensible to do it at this point in time? And I think that's where you have to rely on a really good doc.
All right, we'll cross that bridge if we get there.
Anybody have any advice for David on how to deal with these 2 different doctors' opinions? That's what's sort of intriguing me, and that's the sort of thing that we as patients can maybe help with. Anybody want to put their hand up and help David with that one? I see. Use your hand up function, Sam. But I see you have your hand up. Use that hand up function, and then we see it. But go ahead. You're muted.
You're muted.
I deal with 2 different physicians, an oncologist and a urologist. And when they differ in opinions, when they differ in their opinions, I express person A's opinion to B and person B's opinion to A and see how they come across. And then let your decision come after that. But I would certainly share with each one of them what the other physician's position is.
Thank you.
Aren't these 2 docs at the same institution?
No.
Oh.
One's at Hutch and one's at OHSU, Len. Danny, you have some thoughts on this one.
Just a quick one, David. So, you know, I'm pretty new to this as of November. That's when I got diagnosed. And I went to 3 different places, 3 different oncologists, 3 different radiation oncologists, a couple of different geneticists, genetic counseling. And they all kind of came up with a different combination of treatment sequences and paths. And ultimately, I had to, you know, drive my own treatment. And it was the combination of taking all those different inputs and finding someone who was the right person to quarterback my journey here. And I was fascinated by the differences and opinions on what I should do, what I shouldn't do, and in what order I should do it in. And sometimes it's kind of fascinating that they don't all agree. And you know, you get a radiation oncologist or a GU oncologist or a someone else who sort of specializes in a subspecialty, and they'll have different opinions. And it's not that they're necessarily outright wrong, but it's that they just have different approaches and opinions to treatment and treatment sequencing. And so ultimately, in my journey, you know, I found someone who picked up on a little genetic detail and said, well, if you don't get this treated right away, something else is going to be a problem down the road. So, you know, it's up to you, unfortunately, to have to make those decisions to find out what the right answers are. And it's a practice for a reason. You know, it's not perfect. And then that's my opinion.
Thank you, Danny.
All right, David, we have to move on.
All right. Thank you all. Thank you.
Keep us posted about this, and we'll go to Craig Christensen.
Hi, Len. My question, I have a logistical question, and that is regarding accessing doctors via telehealth when one is not in the same state.
Well, the doctor will tell you if he's licensed, if he or she is licensed to do telehealth in your state. If it, you know, if the doctor is in another state, they'll tell you right away, no, I can't do that.
Yeah. Okay. I guess I've experienced this once, and hoping that it's not an issue, but like with University of California, San Diego Health System, I'm not sure that whether they just have more of a system sort of thing. You know, when I went on the line, they wanted to verify where I was, and if I didn't know to ask whether the doctor was licensed or not, and maybe that's a long shot, but
yeah. Well, of course, the other, I didn't tell you this, but the other option is you just tell them you're in their state.
Yeah.
And let me say that there's a certain doctor that we've been talking about today, and their advice was to do exactly that.
Really?
Just say you're in the state.
Really?
So,
okay.
You know, I think if they don't know now, you're in San Diego. Your home base is San Diego, correct?
Well, actually, I'm half the year in Colorado, which is where I am now.
Right. So just tell them you're in I would just say that you tell them you're in San Diego. I think that's probably, if you have an address in San Diego, you say I'm in San Diego. Call me on this number. Do you have a San Diego number or a Colorado number?
I have a cell phone number, which is a Colorado number.
Okay, you just tell them I'm, you know,
yeah,
I've got a Colorado number, but I'm in San Diego. They're not going to argue with you.
Mm-hmm.
Who did you choose as a quarterback? Because the last thing I have in there is you needed to choose a quarterback.
Well, I had a visit with Dr. Rana McKay, who I like a lot. And yeah, just real quickly, my PSA, so I keep thinking I'm verging on recurrence, but my PSA for the last couple, 3 months times has been 0.13, 0.13, and then 0.12. So I'm not sure whether to get a PSMA scan at this point or just keep watching the PSA, which is, if it's flat, that's great.
Well, you know, again, you got a great doc, okay? And you got also a doc who doesn't overtreat. And I would rely on that doc. When she needs a PSMA, she's going to say, you know what, we better get that PSMA scan. Now, there are other considerations, but you're not on any treatment right now, right? So if you're on treatment, we could say, well, you know, we don't always see it when you're on this drug or the other drug, but you're not on any treatment. So I think you have to rely on Dr. McKay, and she's a great doc.
Sounds good.
Len, what would you say? You're the expert on that. Do we rely on PSA or not?
Yeah, it's a controversial topic because sometimes PSA and PSMA are kind of coordinated with each other, and sometimes they're divergent. So, I mean, I had a PSA of 0.17 And I did a PSMA scan and I had like 8 lesions. So, you know, it depends.
Okay.
Maybe you just don't produce PSA. Maybe you did it one time like I did, and then all of a sudden I stopped producing PSA, or it's greatly diminished. It's a toss up there.
Yeah, and you know, if that concerns you, you can talk to her about it and say, well, you know, but there's this guy in the AnCan group who was at 0.17 and he had 6 lesions, and you know, do you think we should do a PSMA? And see what she says. Look, you know, we see it. Sometimes they'll show up. I mean, look at David Dittmar, who with a 0.04, and we've got lesions showing up. So people are different. I mean, you know, my first gut is I would rely on McKay because she knows all the literature. But my second is, if you're nervous about it, discuss it with her, and she's not going to be too reluctant. You know, once you're back in San Diego.
Right. Okay. And so, yeah, good enough. Thank you.
All right, Craig, thank you.
Thanks much.
Robert Anderson, you are up.
A quick update. I was on a treatment holiday for a year. PSA went up to 9.32. I've been on monotherapy darolutamide for just under 6 weeks now. Went in today. My PSA was down to 0.01.
Wow. Awesome.
Yeah. So things are in the right direction. So
We
that's good.
love Darrow in this group.
Yeah, and how are you feeling? More important on the Darrow, Robert?
Good. No issues.
Oh, that's great. That's great. That's great. That's great. You'll have to tell your friend Dr. Abel that it's working for you.
I see her in 10 weeks.
Oh, there you go. Okay.
Is that Darrow on top of Orgovix or Darrow by itself?
Mono.
Mono. Wow, great.
Yeah. Yeah, I had what I just referenced, those 8 lesions after a PSMA PET scan. And I consulted with the radiation oncologist. He said, well, I can hit all of them. And I was like, oh boy, what's going to happen to my bowels if you hit all these lesions with radiation? So I just opted for Darrow monotherapy. It disappeared. Yeah, I mean, one SUV was 27.
Wow.
On the lymph node on the left public wall. So for me, that's been a miracle drug.
Excellent.
All right, we're going to go to Saranon.
Anybody? I just want to check if anybody else wants to say anything to Robert about their experience on Darrow. And also, I just want to mention to Bill Lawler. Bill, we've heard since we spoke to you about guys with SUVs who are in the high teens and the low 20s and the high 20s. So that just gives you a frame of reference for SUV.
I've been listening.
Yeah. Yeah, so your SUV of 2 point something is starting to look pretty tame. All right, Saranon, are you with us?
Yeah. I think the last meeting, I haven't been on this meeting for about 3 months or so now.
Okay.
Since then, I have completed my radiation, and I have taken my second Lupron shot, and early the epalutamide was added to my medication. So I have completed about 2.5 months of that. My PSA now is under 0.03, 2 readings for 2 months. I feel excessive fatigue brain fog and things like that. That's what's happening right now. Brain fog to the extent that I couldn't remember my own Social Security number. And there's the fatigue is there, so that's what it is right now.
Sorry, could you tell me again which drugs you're on now?
Erleada, which is apalutamide, and Lupron.
Okay. Maybe you can ask your doctor to switch you to darolutamide from apalutamide. There's less, it doesn't cross the blood-brain barrier. There's less fatigue. Of course, you still have the fatigue of Lupron. And maybe there you could even try asking if you could switch to Orgovyx, which some people say doesn't cause as much brain fog. I don't know. I've never had it.
Yeah. Or if Dr. Paul was here, he might even suggest
E2. Yeah. Estradiol.
Are you is Dr. Schmulowitz running your care?
Yes.
Okay, well, he's very empathetic to this brain fog. So I think that if your insurance was willing to deal with it, he would probably switch you to Orgovyx plus darolutamide in a heartbeat.
Okay. Yeah,
Dr.
I'll
John,
talk to him.
Your hand was up, John.
I was just going to ask if Schmulowitz was doing this, and Rick already got there.
Okay. Sam, I'm sorry, I accidentally put your hand down. Sam.
It's okay. I did a year of Erleada and Orgovyx. And the only thing I experienced a lot of was hot flashes. I did not experience brain fog from what I hear other people have experienced. But for me, the combination of the two drugs really just caused hot flashes, gynecomastia, and some tiredness that I overcame with an afternoon nap. But I played golf every day through the entire therapy.
Well, that's great. And we all react differently to the same drugs. So you never know until you try it.
Mm-hmm. Thank you.
Okay, any questions for Saranan?
Or suggestions, comments. I guess not. When are you next? When are you next in touch with Dr. Schmulowitz, Saranan?
My appointment is on July 24th. I was there week before last, but my next appointment is July 24th. But I can reach him through the portal.
Yeah, you can go. When you were there, the week before last, did you tell him what a tough time you're having on the on this doublet of Lupron and?
My appointment was with the RNA, and I mentioned that.
Okay, but that doesn't work.
Mm-hmm. So I'll reach out through the portal.
Yeah, you need to talk to him directly.
Mm-hmm.
Because a lot of times with the nurse navigators and the physician's assistants, they hear it, but they hear it from everybody.
Mm-hmm.
And so they don't, they put it in the notes, but they don't make it. They don't make a deal of it, or they don't raise it with the doc. When you sit across the table from Dr. Schmulowitz and you say, "I'm having a really tough time, Dr. Schmulowitz," then he hears you and he'll do something, which means that on that July appointment, insist you don't accept a physician's assistant or a nurse practitioner.
It is with him.
You've got to sit across and see it, look him in the eye and say, "I'm having a really tough time."
Okay.
Okay. We've got other guys with Dr. Schmulowitz who have done that, and it's worked for them.
Yeah, it was doing pretty good in the beginning, but then as I took more early, I think that's what happened.
Well, I think that I think that if you put it in there and say, can I have a phone appointment with Dr. Schmulowitz between now and then, because I'm having issues and I'd really like to talk to him. And they'll give you a phone appointment and tell him on the phone, and I bet dollars to donuts he'll switch your treatment for you.
Sure, thank you.
All right, thank you. Dennis Young, your turn has come. You're muted, Dennis. Still muted.
No. So Dennis, there should be at the bottom of the screen, there should be a little white box with a microphone in it. Oh, it looks like he stepped away.
I got it.
Got it.
Thank you. Anyway, so I tried to get a new doctor at Fred Hutch. So I put in a request to change to Dr. Fong, Larry Fong.
Right.
And they sent me to the patient relations board, and the patient relations board, they're going to do a 2-week review of my situation and see if they can put me with the doctor that they feel would handle my case the best. So I sent a note to Dr. Fong and asked him to consider me for a patient and told him what I'm going through, and hopefully it'll work out.
Did you mention you came from AnCan?
I did.
Okay.
Absolutely.
Okay. Well, that may help.
Yep.
Because he is on our advisory board after all.
And both letters I sent, I mentioned AnCan, so hopefully it'll work.
Okay. All right. Well, I hope that I hope we can get you sorted.
Appreciate it. Thank you.
Yeah. Yeah. I owe him a letter. If I can get my act together, I will write to him, because he's seeing a couple of our guys now. The other guy that he's seeing isn't on here tonight, but I will, and I'll try and get it done. But I think you'll be fine. And I'm glad they have some sort of a process.
Yes.
But to take somebody from Dr. Chang, even though David D has had a few issues with her, but even so, she's very, very experienced. And to take you from that level of experience to somebody who's a relative newbie, that's not right.
Well, I hope it'll work out.
We'll keep our fingers crossed for you. Let me see. Do I have a fingers crossed emoji? I don't think I do.
Has Dr. Chang actually left by now?
Yeah, she's not. I don't think she's seeing patients. She's supposed to be doing some genetic research.
Oh, I see.
She told me that she got a new appointment or elevated to a board, something what was a new assignment, and she had to winnow her panel down. And I guess I was on the stay with Chang side, and Dennis was on the not stay with Chang side.
Yeah. Yeah, I think they figured they got me all figured out.
Well, they haven't, so there you go. There you go. All right.
We're going to go next to Eric Curtis. Eric, just unmute and start talking.
Got it. Can you hear me?
Oh, yeah.
Okay. So I joined the meeting 2 weeks ago. Unfortunately, I can only join on Mondays. Just a quick review. I've 25 months on Orgovyx and darolutamide, and I thought it was time to take a vacation. I have a team of doctors at UCSF. They said, it's your decision. Do what you want to do. Don't expect it to last very long. And I have an oncologist here locally who said I would not recommend that. So I actually went an extra month on continued with the drugs before I finally made the decision, which was as a matter of the decision that I came to after having this discussions with this group. And
David,
and
just
also
Eric, just two quick questions. What is your PSA and what is your Gleason score?
Oh, my Gleason score is 4+5. It's 9.
Okay.
Yeah, and
Current
I've got
PSA?
and my PSA currently is 0.07.
Okay.
It was 0.02, 0.03. It's at 0.07. I'm watching on a monthly basis. Most recent assessment was on the 29th of May, and that was the exact same reading as it was on the 29th of April. And that's where it's been. And I stopped taking drug. I went on vacation on June 1st. So I'm just only 2 weeks into it. I have a sense that I have more energy, but it's probably way too soon to be able to tell. I know I was on Orgovyx, and going off does help me sort of regain normalcy a little more quickly than if I'd been on Lupron, but I'm not real sure about how long I can expect. Obviously, at this point, I'm keeping track of indicators. That's the game right now is what's happening with my PSA, how am I feeling, and watching these things going forward. My question is, I know that there are other individuals that are on this meeting tonight who have gone for years on hormone therapy continuously. My understanding was that there are issues with continuing to use these drugs on the trouble with my bone structure deteriorating, potential trouble with my heart being adversely affected by the continuation of these drugs. How is it that those of you who have taken this for 8 years or so are continuing to survive? And Jeff, I see you gesticulating. Have you developed osteoporosis, and do you keep track of that? Have you developed heart disease, and how do you mitigate that and continue to take medication? If you don't mind my asking.
8 years, you're right. And I just had a DEXA scan a few weeks ago. It was osteopenia. I took Zometa for 2 years, which is supposed to freeze things for about at least a year. I was on Fosamax for 6 years before that. Mm-hmm. So I've been on bone strengtheners all along. I had 5 AFib events. I had one about a month and a half ago. And I was actually talking to Hard Stark, my oncologist, today about this. And she felt that because I've been on it so long and that's the worst I've had happen, and I have no other heart issues. I don't have skip beats, but I don't have any pain. I don't have any heart. There's no side effects. They don't ever find anything on an EKG other than skip beats or AFib, that I should stay on it and continue on it because it's working for me. And I am castrate resistant to ADT. But
that was my next question.
Yeah, not all your cells are castrate resistant. Some of them are, sometimes some of them are not, because they don't all turn over at once. And that's why I'm on it. It does keep my testosterone down real low, and she wants it
It'll
staying.
do that.
Yeah. So that's, I went over this today. This exact. In fact, I saw some conflicts between Orgovyx and Diltiazem today. I was looking and saw that there was a conflict where it keeps Orgovyx in your body longer, and she checked a professional database of drug conflicts, and she says it's not a problem. It isn't on there in the professional databases. So I went over both of these today, this morning, and she just felt I should stay on it. And you know, you have to take a look at your heart and what's going on. Abiraterone gave me, put me on 3 blood pressure medications, but my blood pressure, I went in today and it was 101/64. And my blood pressure is never over about 110, almost never. And it's always in the 60s for the, you know, you've got to look at yourself and see what works for you. And I don't know if you have any other questions, but that's my answers.
I appreciate your openness and you're willing to share that with me, because that's where my thoughts have been going. I'm constantly
there's another alternative. There's another alternative, which a bunch of the guys in this group have used. And if you start to see some increase in that from that 0.07, which is monotherapy darolutamide. Somebody wanted to, Len, you can talk about monotherapy darolutamide and anybody else who's in the room.
Yeah, I've been on intermittent monotherapy with darolutamide since 2020. I've never, since 2020, I've never taken any ADT drug. And like you, I'm a Gleason 9, and I've had, along the way, I've had lymph and bone metastases. I just had a CT scan, chest, abdomen, pelvis. Everything looked good. No evidence of metastatic disease, they said. So, but again, you know, that's me. Doesn't mean it will work as well for you, but it could. Now, you also have a couple of factors, risk factors that I didn't have, like you have cribriform, right?
Yep.
And you have, well, your Decipher score was 1, which is, you know, way up there. I never had a Decipher score, so I don't know what but I'm sure it'd probably be 1. So, yeah, I mean.
And then back in the day, we weren't looking for cribriform when they looked at your pathology.
True. Yeah, right.
Yeah.
So, I had a interesting side discussion this week with Dr. Paul, because he came back to us after last week's meeting and he said, well, should you really be talking about intermittent therapy? He came back to all of us, and then he followed up with me on a couple of aspects. He said, should you really be looking at things like intermittent therapy, because it's not in the NCCN guidelines? And we said, you know, the guidelines are exactly that. They're guidelines. And other than with enzalutamide, and it was sort of a sidebar of the trial, they really haven't tested intermittent against continuous in a doublet context. They've done it with singlet, but not in a doublet. Nor have they really looked at monotherapy other than this one enzalutamide trial. So what that means to us is that we should be looking at what some of the doctors that we like and we respect are doing. And a lot of them are willing to go with monotherapy, starting, for example, with Dr. O and Len, or Dr. Shmulewitz, or Dr. Efstathiou. And we can keep rolling some of these people, some of these great docs off the tongue. So the fact that it isn't in the guidelines doesn't mean that it isn't appropriate. You know, so I would say, good for you taking the break. Let's see how you do, and then if you need to restart, then there are some options. Saranan, you have your hand up. Is it on this topic?
I have a question for Eric.
Go ahead.
Yeah, Eric, I also have crib reform, and my decipher is 0.98, and my crib reform is large cell. Do you know what yours is?
I'm sorry, I don't.
That was my question.
Okay. And who did that? Who did that? Who did the original pathology, and did you get it reviewed, Eric?
Hey, the original pathology was done locally here, and I had it reviewed in San Francisco.
Okay, well, you can ask San Francisco to tell you if it's large or small, and you should do that.
Okay.
Okay, anything else, Eric, we can help you with?
No,
Or?
no, that's, no, these are just, I'm sort of at the turning point for me, and ideas come up and I have concerns. I really appreciate the opportunity to put my concerns out on the table amongst gentlemen who have all dealt with these issues in their own personal ways and have had their own personal solutions to their concerns. And they're willing to share them with me, and it helps me take a look at the options that are available and decide how I want to go. Makes me feel a little bit more comfortable about the decision I made. I am thinking now there's going to be a point where I'm going to end up going back. The vacation will be over. So then there's a question of whether I want to take a step in, perhaps just straight darolutamide for a while and see how that goes. Whether I can, keep my PSA. The PSA is the primary indicator, I assume, at this point. And I want to keep that under control. I do not want to allow metastasis to develop further than it has already. And but I want to be smart about it. So perhaps trying mono for a while and seeing how my PSA responds would be a good idea. I don't know. I have to talk to my docs about that. But I appreciate everyone's candor. Thanks.
Dr. John, go ahead.
Eric, you said PSA is the prime indicator. This is a fight I have with my own doctor. Is it going to be your only indicator, or are you going to also get scans every 6 to 12 months?
As in PSMA scan?
Yeah.
Oh, there's been no discussion about that. PSA has been primary. Only if PSA gets to 0.2 or above, are they going to probably recommend it. I mean, that's my understanding. I don't know that. Can I make a request for it if I'm at 0.07? I mean, I don't know that you can even see anything when PSA is at that level.
Well, that's exactly what my oncologist is going to do with me. He's going to wait till it gets to 0.2 and then do a PSMA scan.
Yeah.
However, every year it seems like there's a little bit more evidence that recurrences can occur without biochemical recurrences. That radiographic recurrences can happen before biochemical recurrences. So that's why I was wondering what they're planning. You do produce, your cancer does produce PSA, so PSA is a decent biomarker. I just don't know whether it should be the only biomarker or not. But if you do get any information about that, please pass it on.
Absolutely. I mean, that as I said before, this stage for me, I'm trying very hard to pay attention to what's going on here. And if things change or develop, I want to know about it and I want to do something about it. PSA is an indicator that I've been told to rely on. If there are other indicators that are available that would help me pay attention to what's going on, I'm all ears.
Okay, Sam, you're next. Go ahead.
Yeah, it seems like there's a lot of ambiguity for all of us, especially if we're on vacation, as to when we go back to treatment, because the questions, I mean, what I've heard from my guys is that a PSMA may not be very accurate when you get below 1.0, and that its accuracy improves dramatically once you're at a PSA level of 1. But there doesn't seem to be any hard and fast rule as to when you do go back on therapy, unless you've got something detectable via a PSMA with an SUV greater than a certain number. And I just wondered if there seems to be, if there is any consensus as to when those of us who are on extended androgen receptor blockade, when we do go off and then when we go back. I mean, are there any kind of specific guidelines?
I don't know.
I don't
Anybody
think so.
else?
There's a general agreement that a recurrence is, what is it, three increases in PSA, and reaching 0.2 is the time to consider going back on treatment.
Dr. Jack.
Or nadir +2.
You know, it seems like the general consensus among our oncologists is that, you know, the 0.2 point and then PSMA scan. Some people believe FDG scan. But I just, I wonder to what degree, John, when you talk about, yes, it can occasionally occur, in spite of the fact that your PSA is so low, and that, you know, maybe we should cover that by doing a scan, even with a very low PSA. How frequent is that? What does the literature say about that? It seems like it's such an exception that it's hard to justify, you know, doing scans on all of us prophylactically when the PSA is as low as it is when we're on a holiday, let's say for a year or two, or not on a holiday. So I wonder how, you know, your concern about maybe getting a PSMA scan with a very low PSA, where that's coming from, other than exceptional cases that show up with reoccurrences with low PSAs, and whether or not that's, you know, the beginning of something other than an adenocarcinoma.
It's not insignificant. Isn't it like 15 to 25% in arches? And then there was another study after that showing similar numbers. It's not insignificant. But then, you know, even if you get radiographic recurrence before PSMA recurrence, does that then mean it should be treated? Should you treat radiographic recurrence before the PSA comes? You know, that question isn't even answered, as far as I know.
Well, if you've got radiographic progression with conventional imaging, certainly you would be treating it then. Is that, or are you only talking about PS?
Well, yeah, conventional imaging. Well, Arches was all conventional imaging.
How do you distinguish between radiographic progression that's actual progression versus dead tissue that's necrotic and has been radiated and it looks like it's progression?
It's a good question. I guess you have to compare it to previous scans of the same type, like previous CT scans, to see if those lesions were there or if they're new. If they weren't there before, chances are they're not just, dead, formerly treated lesions, that they're active. I don't know how else you would do it. Jan Nielsen, go ahead.
Just wonder if doubling time comes to play at all.
Yes.
So, it's always important.
Well, everybody, the other two jump in and say yes, and I would jump in and say no, because it all depends on the on the initial size. I mean, if you're at 0.06 and you come back 6 weeks later and you're at 0.09, I would say no. If you're at 6 and you come back and it's at 9, then yes, for sure. So, in that long game trial, they don't pay a lot of attention to PSA that's under 1.0. They're not going to pay a whole heck of a lot of attention. So yes, doubling time can be important, but it depends on the absolute amount of the PSA. Now, I'm going to refer back to my two moderators who both quickly said yes, yes.
Well, yeah, I agree with you 100%, Rick. Yeah, anything below 1.0, you don't really think about doubling time. And that's coming from Dr. Guanchel, who would know about such things. So, that's her rule of thumb. Don't talk about doubling time unless your PSA is over 1. Go ahead, John.
Agree.
Yeah.
And I would want at least 3 measurements too to get a good curve, so you're not basing it on 2 points.
Yeah, sure.
Robert, you had your hand up and then you took it down. What were you thinking?
I was going to mention the PSA doubling time too, just because I have some experience with that.
Oh, right.
Rapid.
Okay.
Yeah.
Doubling time is a great biomarker in the upper numbers. I agree.
Gao Shan, let's see if we can get you in. Are you still with us?
He's still with us because I can see, but he's got his. Are you there, Gao Shan?
Yep, I'm here. I just had to get to all of the open pages I had to find you back. Yeah, so anyway, I just wanted to let you know, I've been at OHSU since 2020, and I originally started with Dr. Vuki, but she went to research, and then I started working for 2+ years with Dr. Graff, and I now have my first appointment coming up on the 24th of June with Dr. E. And I have a PSA test here in Panama before I fly back to US. And then I have about, 20 some blood tests when I'm in the US, including PSA and testosterone. My last PSA test was 0.12. And I've been off of ADT, which is the only drug I've had. I've been off of that going on 4 years now.
Sounds good.
So we'll see where I am now with these blood tests coming, and And I'm really looking forward to meeting Dr. E. So that's set for the 24th of June. So,
how's that broken arm?
well, I'm getting movement in some directions, but some directions are a little tougher. And with the movement and rehab I've been doing, rehab session 10, my tendon got tighter than last year's bathing suit, so I've been dealing with that. And sometimes it's impossible to even touch it. So I've been using cold packs 3 times a day, 2-3 times a day. And then they're doing electrical stimulation and ultrasound. So, but it's going to be a long process. It's not going to be over in a couple more months, I don't think. I mean, it's improving, but slowly. And the big problem was I broke the bone right at the neck of the ball joint. So that's tougher than just breaking your arm. So thank you. I'll give you an update after I see Dr. E.
Okay.
Thank you.
Rick, Galshan was our last.
Well, Jan had a question, and he
Yeah,
said
but he just left. I don't know if he came back. He just left like minutes ago.
Oh.
Is he still here?
No.
No, he left.
He left. He left when we turned 7 o'clock. That's what happens when you do that. We were willing to take him.
Yep. Well, he made it sound like it wasn't very important. He said, "Put me at the very end, if there's time." So I don't know what he wanted, but
I never do that. If they want time, they want time. We give them time, and somebody else. Who was it? Somebody else who said, "Oh, Keith." We couldn't hear Keith. Is Keith still with us? Keith said he didn't, and then he did. I think Keith may have.
We had a lot of people drop out. We do have a question from Dan. Go ahead, Dan. Schenectady.
Just a couple follow-up questions. I went back and read some of his notes, and he said he was going to have a stepwise approach to my treatment, and because he wanted to know the ribs associated with my lower back pain, and also too, I wanted to know that I forgot. I want to know, is there a difference if I have 5 or 6 lesions and bone lesions, whether the chemotherapy would be considered or not, or 5 is the number?
I think there's flexibility there. It depends. You know, they have to use their clinical judgment.
Okay.
There's no hard and fast number.
Okay. Yeah. Because he said he wanted to use a stepwise approach, and to then find the cause of the pain in my back, and then look at the medication and the radiation after that. Is that reasonable, or what do you think?
I think he could say, okay, we'll pursue it on the, he could say we can switch the medication. He could say we could switch aspects of the medication, or he could say it's time to do chemotherapy. And, I think that what the way I would respond to that is, well, if I was your father, what would you tell him?
Right. Okay.
Yeah. This is where different docs work in different ways.
Right. Yeah.
And we've had some good experience with McHugh. We've had some not so good experience with McHugh. It's hard to tell. I don't know what he would say. So there's no point in second guessing. But if he did say to you, it's time for chemo, I mean, is it a different? Is there a big difference between 5 and 6 lesions? There's a big difference between 4 and 5 lesions. Let me say that, okay? Because we talk about oligometastasis as being maximum 5 lesions. But there are some docs who, if you've got 5 lesions, they figure that that's high volume already. I think with 6 lesions, there's no question that most docs would say that is high volume, but we're willing to try other things. You know, if you had 4 lesions, and the doc said, I think that's high volume, we'd say, well, it all depends on the doc, you know. So the 4 and 5 is really the area where it cuts off. 6 is a little on the high side.
Yeah,
that's what I would say.
Yeah, I counted them, and it was 5, and so that's why I asked the question. Yeah, because no patient in the report does he make chemo. So
you, I mean, are you including the lymph nodes?
No, just the
Okay,
bone.
so you've got to include the lymph nodes. So it's really 7.
Gotcha. Okay. All right.
Okay.
Yep. Thank you.
So, you know, you're sitting there with 7 lesions because they will count the lymph nodes as qualifying. It's not 4 or 5 bone mets for oligometastasis. It's 4 or 5 lesions. Now, if somebody comes in with 5 nodal metastases, and the doc may say, yeah, but there's nothing in the bone yet. It's not that distant. So maybe we'll go easy. But when you've got 5, I'm guessing, I don't know, Dr. John, if you had 5 lesions in the bone and 2 in the nodes, how many lesions would you count that as?
7 high volume.
Okay. All right. And
sorry.
Thank you very much, and thank you for your patience with me.
And Dan, I think you've got to really rely on Dr. McHugh, and you've got to take his guidance, and I think you've got to push him. And if he decides not to give you chemotherapy, I would definitely say to him, look, if I was your father or your brother or what have you, what would you tell him?
Right.
Anybody else want to chime in on this one?
Dan, what I would say to you also is what do you want? You have to sit down and think about what does Dan want Dan to do?
Mm-hmm. Right. Right. Yeah. Yeah, that's why I asked the question, so I can decide on my options and what's best for me, so.
Did your wife tell you why she was dead set against the chemo?
Well, I guess because she didn't tell me why, but I guess because she heard such bad stories about it. People with chemo have such a hard time, and like that. So she doesn't. She hasn't experienced anybody who actually had chemotherapy and survived it.
Okay, well, you could tell her everybody in this group's had it and they survived it.
I will.
Mr. Markey, you never had it. What are you?
But I got a comment. The one guy over in the CSC group, they meet twice a month. And he talked about how he had 15 metastases. He went in for multiple sessions and had them all zapped. Well, you don't fight. I think you have a hell of a time finding a doctor that'll do that for you, but he did. And it worked for him. So it has been done, but with more than 5, but the standard is, and that's why I didn't mention it earlier, because Ricky brought up the fact that it's likely to just have more come. And you know, you can zap all you got, but what's the future?
Right.
But I know it's been done, so I just thought I'd mention it.
Yeah, that seems like the direction he's going from what I find in his reports. So
I think when you start getting up that high, Jeff, you have to start worrying about what kind of damage it's going to do to your bone marrow, your immune system.
Right.
Yeah.
Right.
Okay. Rick, I'm ready to close out.
I think you
Captain
did a
Jim
good
just
job.
gave me a salute. It's time to go.
That's it. All right.
Oh, and my Secretary of Defense is saluting me. All right.
Okay, thank
Bye,
you,
Sylvester.
thank you.
Everybody. Thank you.
Next week.
Nice job.
Bye,
Have a
thank
good one.
you.
Good night, everybody.
Thank you.